Okay, so if you've got that terminology down, come on into the classroom here and let's put it to use as we would really practically in a bodywork practice. There's one thing here that's not as I would set it up in a bodywork practice, and so let me give you this tip ahead of time. And that is if you're doing this with a client in your practice, because some of you are perhaps not used to doing that. If you're a massage therapist, you see them dressed, you go out of the room, they come back, they're under a sheet. So it's a little bit confrontive to look at people in their underwear in this society where you're really judged by how your body is. A way to take some of that sting out is to put the client, let's imagine that Penny's here in my practice, I would have a full-length mirror here in front of Penny so that she could see herself. And I would stand back here so that I could see her reflection, so I can see her front, and back here so I can see the back and the side, whatever I need to see to do the body reading. And then my my procedure is to elicit from her what she sees. I will tell you that most people in Western culture will have a very long and detailed list about what's wrong with their body and a very short and vague list about what's right with their body. And this is this kind of body image thing that we're fighting to have people authenticate, to feel good about being inside themselves. And we have a culture that's a consumer culture. It is dead set on making you feel bad about what you have, so you'll go out and get something else. So anyway, you can take a lot of the sting out of this by putting them in front of a mirror and having them tell you what's going on. And that means that you and them are looking at the image in the mirror rather than you standing in front of them and confronting them. That's not going to work in class, so we have you standing up in front of class. Penny's very kindly consented to be up here. Before we start using tilt, shift, bend, and rotate, what we were just practicing a few minutes ago, I want to put a couple more things in here that are very important as we start. One is your first impression. Don't know if you've read Blink or Malcolm Gladwell's thing, but a host of information goes into your first impression. And to get a first impression of Penny here, look at her and look away, or look at her and close your eyes. And then bring up that mind's eye image and see what it says to you. What is your first impression? Don't tell me right now. That's just your own first impression. Besides, you can't put into words all the things that you pick up in that first impression. It's a very rich thing that happens in your unconscious. And again, we've all had a lifetime of people watching, so we're all very adept as animals. That animal perception comes out and takes in that first impression. And so that's a very important thing. That's number one. Number two is, this is very important too, it's so easy to turn your client into a set of problems. I can't tell you how many times I'm out on the lecture circuit, somebody comes up and says, well, I have this frozen shoulder. A client at home, she's a frozen shoulder. That whole client has just been reduced to one problem. Now, however many things that Penny might like to say is going wrong with her body today, I can tell you absolutely assuredly many more things are going right than are going wrong with her today. And if you reduce her to a set of problems, you miss out on all the wonderful advantages that she's bringing to the table. So, before we can go anywhere with tilt, shift, bend, and rotate, you have to tell me 3 good things that Penny is bringing to your work together. Whatever work that's going to be, body work, movement work, psychological work, I don't care what the work is going to be. What are the things that she brings that are positive?
I think she's doing a great job of staying upright with gravity pounding down on her. I just see such upright, strong posture.
All right, so she's already coming in with the basics of her posture in gear. That's a good thing to know. It's not only positively reinforcing for the client, it tells you you don't have to do certain things. They're already done. She's already got them. Let's take the things that really are challenging for her and not spend time on the things that aren't her challenge. And one of her challenges is not where is basic posture and where is the basic lift through the body. She's really got that down. Great. All right, that's number one. Who has another positive thing to say about Penny?
Penny brings a lot of strength and a lot of balance and a lot of energy. You could see it in her eyes. You could see, and just in the form that she presents.
Great. So one of the first questions that we ask when we're going to work with somebody is, what is the capacity, what is the energetic capacity of that system? You can see in her muscle tone, in her eyes, in the openness of her expression and the alertness of expression that Penny's got a lot of energy in there. If somebody comes in, I'm thinking of people with fibromyalgia as a class, excuse the generalization, but they often are energy-less, strangled in their ability to come out. I'm not going to work with that person the same way I'm going to work with Penny. It's going to be different. We've already got the energy going. That's great. That's number 2. We don't go nowhere till we get to number 3. Do you think they can think of 3 things?
Come on,
good,
people.
3 good things to say? Great.
She seems strong and confident, square. Her shoulders seem even and kind of grounded, and just strong and confident is what my impression is.
Okay, so that confidence actually speaks to the condition of the spine. Confidence and the spine are very much related. So she is expressing her ability to be in the world with confidence by the way her spine is. Yep, that's great.
Well, I just noticed that her head is so beautifully set on her shoulders and her neck, and she's just, her God-given attribute is that she's very beautifully proportioned.
Now, is that God-given or
I'm sure she's worked on it a
man-made,
great deal.
woman-made?
But her proportions
Yeah, she started
are very,
out
very fine.
with some good proportions and has kept them. We could list many more positive things, but we're going to do that exercise every time somebody stands up here because it's very, very important that you get into that habit in your practice of not going immediately to this hip's higher than that hip. This is a problem. The breathing isn't happening here. We're going to now take Penny and tear her into little tiny pieces. Yeah. Because there are a lot of things, even in somebody with a very good structure, there are always things that you can find. Because we're just taking Penny from where she is and not comparing her to Iyengar or Pilates or anybody else in the whole wide world, but to Penny how she could be. And Penny how she could be, there are improvements that could be made by her, by us as a therapist. So let's have a look at what those things could be. We're going to look at where the skeleton is using tilt, shift, bend, and rotate. Then we're going to look at what soft tissues could be helping to hold that in place. And then we'll go a little bit into what kind of strategy we might use. But since this tape is going out to people who use all different kinds of methods, we're not going to go so much into method. Really, what do you see and what are the soft tissues that are holding it? That's going to be our main deal. So in order to do that, let's look at the 3 major axes. Left, right, front, back. No, you can stay right where you are for a sec. And top, bottom. Now, we're going to have to nitpick a little bit because if I drop a line straight through her sagittal plane, you can see that she's fairly balanced left and right. Yeah? She's fairly symmetrical between left and right. Having said that, what differences can you see between her left and her right?
Her right shoulder is higher than her left shoulder.
Her right shoulder is higher than her left shoulder. Can you see that in the clavicles too? Do you see a kind of tilt in the clavicles?
A little bit.
A little bit. So, yeah, so everything we're going to do with Penny is a little bit because she's pretty balanced. But there's a slight left tilt of the shoulder girdle. Why? Because the top of the shoulder girdle is going to the left. The thing I was trying to distinguish between is it just that her right shoulder is lifted, or is it that the whole shoulder girdle is tilted? That's what I was trying to get at when I said, is it in the clavicles? The clavicles should, with all the problems that the word should has, the clavicles should be horizontal. Or at least fairly equal.
Yeah.
All right. If her shoulder girdle is tilted a little bit, is her rib cage tilted a little bit? Is this lower than this? Is my left finger lower than my right finger?
Yes.
A little bit. So it's not the shoulder girdle's fault. Don't go blaming the shoulder girdle. This is so common. What you can see right at the beginning is the shoulder girdle. But, okay, shoulders that way. Are the ribs that way? Okay, the ribs are that way a little bit. Are the hips that way? Because we're on a... Is the hip higher on the right side than it is on the left? Yes. So it's not the shoulder's fault, and the rib cage is saying, it's not my fault, and the hips are there. So how about her knees? Are her knees likewise higher on So we started with her shoulders, and within 2 minutes, we're not working on her shoulders. We're down looking at the lower leg.
It could be my personality.
What, you're tilted in your personality? I don't think so. How about if I put my 2 fingers on the tibial tuberosities, is one higher than the other?
Yes, the right is higher.
All right. So we're really looking at a difference probably between the feet. Something going on in the feet, and it's showing up in the shoulders.
The left foot is medially tilted, whereas the right foot has a little bit more stability in the.
Yes! It's not about the shoulders. Her left foot, oh, Zach, we give you points for using the proper language. Her left foot is medially tilted, or pronated in common language. So that shortens this leg. It's not a short leg in any anatomical sense, but the hip falls into that, the rib cage falls into that, and the shoulders fall into that. And she's going to come in and say, about the right side of my neck. And we're going to say, oh, yes. And we're going to work on stabilizing the arch in her left foot to solve the problem on the right side of her neck. Am I conveying here what is? Because the body is a holistic system. It is a strain distribution machine. The strain that comes from that left arch is being transmitted up the body. This shoulder falls, and these muscles on this side of the shoulder, on this side of the neck, are holding up her head from falling to the left. And those are the ones that are going to complain. The ones that are the cause are down there in the left arch.
How do you know that it's not something like in the musculature that's allowing the foot to pronate that way? How do you know it's starting there?
Oh, I
and
don't.
Not somewhere
I'm quite sure
else
that
up
it's
the chain.
I'm quite sure that it's a failure in the musculature, but the bones are tilted. Whatever the cause, whether it's ligaments or the muscles or the shapes of the bones, I don't know. I haven't taken X-rays yet. We're just getting a picture here. Something has caused that foot to go in, at least so we're surmising, and that has translated all the way up the body. Gravity kind of works from the top down, and foundation kind of works from the bottom up. So it's worth, if you see the shoulders, I'm not likely to go to the head because the head's even less stable than the shoulders, right? It's perched way up there in the air. Shoulders rest on the rib cage, so let's see what's happening with the rib cage. If we'd gone to the rib cage and the rib cage was horizontal, I would have said, yep, something must be pulling down on this shoulder or pulling up on this one or something, because it's not in the rib cage. We just kept going until we didn't see that pattern.
Okay.
We happened to go down towards the floor, but we could have gone from the floor up. The first thing that somebody could, I went from what you said. You said the shoulders, or one of you said the shoulders. So if you'd said the foot first, then we would have worked from the foot all the way up to the shoulder. It's not good or bad or cause and effect. We're just looking for relationships.
So it's possible you might have seen, if you didn't go all the way down to the feet to find the level, you could have found something in the hips.
Yeah,
and
or
not had to go all the way down.
Real simple. Let's imagine that we said the hips were absolutely level. Then we would have said maybe that there was a tilt of the rib cage, and then the shoulder girdle fell into the tilt that the rib cage made. So you just go down as far as it is.
Okay, that was my question.
Yep. Or out as far as it is, or up as far as it is, but you're looking for relationships. All right, now, Madame, you've been standing here for a long time, and I'm afraid you're going to have to stand here some more, but let's change your position to sideways. Okay, and now you're going to drop a line through the mid-coronal plane. I don't know where, through her ear, through her ankle, through her hip. I don't care where you drop the line, but so much is going to be behind that line and so much is going to be in front of it. So first I want to know about the shifts. We got like a set of blocks here. Which block is pushed forward and which block is pushed back? Obviously, when you're looking at the side here, you're looking at the front-back AP relationships, anterior-posterior relationships. So what's in front of what? What did we just talk about in terms of the pelvis? So is that pelvis anteriorly shifted relative to the feet or posteriorly shifted relative to the feet?
Anterior shift.
All right, it's anteriorly shifted relative to the feet. And are the shoulders posteriorly shifted or anteriorly shifted relative to the pelvis? So I can say that this way, I can say that the pelvis is anterior relative to the feet, the shoulders are posterior relative to the pelvis, but the shoulders are neutral relative to the feet, aren't they? So her feet are holding up her shoulders, and her pelvis is holding up her head. That's one way to look at it. But her head's over her pelvis, and her shoulders are over her feet. No, it's not so good. We want them all lined up. Now, but once you see that, let's just, I'm going to jump ahead to the strategy here. If you see that this is forward, then I'll tell you, it's a longer discussion that I don't want to have right now, is the tissue on the front of the leg gets pulled down and the tissue on the back of the leg gets pulled up. If you work in soft tissue terms, I'm talking about manual therapy terms now, so that the tissue in the front of the leg comes up and you bring the tissue in the back of the leg down, you will bring her over her feet. If she does not change the shoulders, her shoulders will now be behind her feet, and she will say, this may look more aligned in the mirror, but it doesn't feel good to me. I feel like I'm way behind myself. So either she's going to go back to where she's accustomed to, or I need to do something with the upper body also to make it make sense. Yeah? But right now, what we see, go to your normal posture if you can remember what it is.
Oh, good.
Yeah.
Whatever you did.
Yeah, it does. We see a bow shape from the shoulder to the ankle, do we not?
We do.
You'll never see another pattern like that in the Western world. Nobody in this world has their pelvis, head, and their shoulders behind like that. Not. You'll see it every day walking into your practice. So this up the front, down the back thing really works. All right, so it's kind of like a Jacob's ladder, that little kid's toy thing. The head is forward, the shoulders are back, the belly and pelvis are forward, the feet are back. Yeah? Zigzag, zigzag. So it's in balance. As I was saying a while ago, everybody's in balance. She's in balance, but it's not the balance we would love to see, especially if we did something like this. Now, Penny, just allow your pelvis to come back over your heels just a little bit. Yeah. You feel her grow. I'm just able to get her head to come. As much lift as she has in her body, we talked about it, that she's strong, confident, and lifted, and core supported. There's that much more in her body yet to come. And not that hard to get. Yeah. Okay, and come back. You're not going to, are you? Come back to your normal posture if you can remember what that is. Good. All right, now I want to ask you a different question. I'm just going to ask you to bend your elbow for the camera here. Is she anteriorly tilted in her pelvis relative to the femur, or posteriorly tilted on her pelvis relative to the femur? Anybody want to take a guess at that one?
Looks anteriorly tilted to me.
Okay, she looks anteriorly tilted relative to what?
It's not the
To the
pelvis.
lumbar spine.
To the lumbar spine? Maybe. I'm going to tell you that this is an example of an anterior shift, posterior tilt. If I put my hand along the femur, and then I put my hand along her pelvis is actually, it should be the letter T, right? If it's, now, we can argue, and people do, about where exactly is a posterior, an anterior, or a neutral pelvis. And I actually don't want to answer that because it changes with the individual. However, I would submit to you that this femur is actually angling pretty far forward so that the pelvis, even though it might be anteriorly tilted relative to the ground, is posteriorly tilted relative to the femur. And here's the news. No muscles attach the pelvis to the ground. Most of the muscles in here, myofascial units to be precise, attach the pelvis to the femur. So if the femur is anteriorly tilted and the pelvis is a little anteriorly tilted, well, then the femur and the pelvis are neutral. But her femur is anteriorly tilted, carrying her forward of her feet, and then the pelvis is actually tucked under. Do you see that dishing right there? That's not talking to you about the gluteus maximus. That's talking to you about, by dishing I mean this scalloped bit here that lots of muscular people have. It's speaking to really deep chronic tension in the deep lateral rotators. And she would need to let that go to be able to be comfortably sitting over her feet instead of somewhere in front of them. Okay? So we've done side to side, and we've looked at front back, and we found more issues in front to back. So she has more. It's just, again, this is something that I do early in the thing. Is this a left-right person, a person who has more issues between left and right? Not Penny. Front back, yeah, quite a bit of issues between where her front line and where her back line are. All right? Now let's turn your back to stay over that white thing, if you would. Now I want to use the back view to compare top and bottom. Is she in proportion between her top and bottom? Or does she look like she has a great big top and a little tiny pipe stem legs? Or does she look like she has great big hips and little tiny shoulders?
She's in proportion.
She's in great proportion. Not an issue where I have to think about, oh, there's no energy in the top of the body and too much energy in the bottom of the body, or vice versa. She's really balanced top to bottom, no problem. And then if you could face them once more. So I'm not going to say anything about that. We'll probably have another example later that has more of that. But go ahead and face the folks again, if you would. Face the camera. I want to do one more thing first. We said we were going to do right, left, top, bottom, front, back, and inside, outside. Core, sleeve. She's got a very well developed core. If we focus in on the lower torso and hips here, we can see that she, how to put this, she struggles a little more to keep the organization going between her rib cage and her hips than she does in her shoulders or her neck or almost anywhere else. There is a large event 12 years ago in her history that might have something to do with that when she gave birth to twins in a difficult birth. And can I be forgiven a political statement for saying that the postpartum rehab in this country is not great, generally speaking? So even though she's taken her own health in hand since, it's very difficult to reestablish the pelvic floor and the relationships in the abdominal balloon, by which I mean this whole thing from the diaphragm to the pelvic floor. It's especially hard to reestablish those relationships 10 years, 6 years after the birth. It really should be done in the year after the birth. So her core is very strong, but right around the hips, we could look for more organization in that core. Finally, though, we need to look at rotations. We were looking at tilts. We saw some tilts in the left-right thing. We were looking at shifts. We particularly saw shifts for her in the front-back range. Now, if we look for rotations, can you see that this shoulder is closer to you than this one?
Yes, we can.
Okay. Can you see, this is harder, but can you see that this side of the ribs are closer to you than this side?
Yeah.
Mm-hmm. All right. Now, for the dishwasher and the trip to Bora Bora, what are these? Are either of these closer to you? Damn hard to tell, isn't it?
The left one?
The left looks a little bit closer.
So still the left?
Yes.
Well, I have the advantage of you because I'm looking right down her back here. And I can tell you, I'm going to exaggerate her rotations. She has a rotation of the rib cage this way and the pelvis this way.
Yeah, I can see that now.
If you think of where her pubic bone would be pointing, the flashlight would be going off to her left.
Yeah, I can see that now.
Her primary rotation, and everybody that I've ever seen has a primary rotation. I've been working this for 30 years. I've never seen somebody who doesn't have it. She has very little, tiny rotation, which is why I'm not going to dwell on it, because we'll probably see a better example before the day is out. But she does have a primary rotation. If I took the pelvis, which is like this, let me get in there. If I took the pelvis and made it square to the feet, you would see, which is exactly what I'm going to do right now. I'm going to take and put my thumbs on her PSISs and my index fingers on her ASISs, and I'm going to locate her hips relative to her heels. And then you can see the left rotation in the upper body even more strongly because she corrects it with a slight rotation to the left. Did I do this wrong in left and right? She has a left rotation of her pelvis relative to her feet a right rotation of the rib cage relative to the pelvis, and so they cancel out. But if I take the one in the legs and I take it out, then you see the one in the upper body even more strongly.
Which is the primary one?
Oh, yeah, good question. Thank you, Lawrence. I define the primary rotation as the one that's the strongest in the thoracolumbar spine. I'm just defining it that way. It's not for any other reason than I'm looking at the primary rotation through the trunk. And almost everybody will have a primary one. Occasionally you'll get somebody who's got a lumbar spine going this way and the thoracic spine going the other way, and it's hard to tell which is primary. But most of the time there's one rotation here. A little bit farther down the road we're going to change our thing here and show you how to look at rotations, because it's very hard to see rotations.
In this instance, you're saying it's the pelvis or it's the shoulder?
No, I'm looking at the rotation in the spine, which is going to do what it does to the pelvis or the shoulder. So the primary rotation, what I'm looking for a primary rotation is the thoracolumbar spine. Yep. Yes, ma'am.
When you altered her hips,
Yep.
she went further into her dysfunction in the other parts.
Well, yeah, but you pays your money and you takes your choice. Now you watch her hips. If I take her ribs and I undo the rotation in her ribs, now the pelvic rotation looks exaggerated.
So what I mean is, once you correct, for lack of a better word, one part,
Yep.
then the equal and opposite reaction in the other body part, it's like a rubber band pulls further into the dysfunction.
Could pull further into dysfunction. It could release on its own because it was just a muscular compensation for this one up here. There's all different kinds of patterns in the body.
It could be the nervous system, something just fires.
Sure. If my head goes over here, then my rib cage will go over here to compensate. If you move my rib cage over here, my head will just keep going, right, over to the left. Because say this is locked. But if I unlock this and bring it back towards the middle, and the rib cage was just neurologically compensated for over here, it'll move back again. I move the head, the rib cage will move back. But if it's been there for years, here the Rolfer in me, if it's been there for years, it's likely written into the connective tissue.
Right.
And then it's harder to change. You can change it with exercise, but it takes some time. You can change it with yoga, because that's stretching the connective tissue. You can certainly change it with the kind of connective tissue manipulation that I'm known for. You can, and lots of other people. And you can change it with chiropractic manipulation if that changes the soft tissue. But that's one of these cases where if a chiropractor sort of zeroes in on the spine and says, well, I'm going to work on this little vertebra, but all the rest of the tissues are still saying, come over here, then it's very hard for that chiropractic manipulation to hold, which is why more and more chiropractors are using soft tissue people in their practices or soft tissue techniques in their own practice, because it holds better. And this is, I'm talking to you who probably understand this idea, but I got to tell you that 30 years ago when I got into this trade, the absolute tenet of this was soft tissue changes won't hold. It will only hold if you put it into the skeletal system. But in point of fact, in 30 years, that's pretty much reversed. Short-term problems will come out if you manipulate the skeletal system. But long-term problems get written into the soft tissue system and need to be pulled out from there.
She has, I would think, very good body awareness. And in someone like her, would she need to be like mentally aware of what's doing what, so she can kind of catch herself and say, ooh, there goes that pesky rotation, let's say.
There goes that pesky rotation. The answer to that question is yes and no. Yes, awareness is helpful, but no, postural things aren't held in your conscious mind. This is the problem with certain people who take up, I'm going after everybody, aren't I? The chiropractors, the PTs, the exercise people. I'm an equal opportunity disser. I'll get to everybody by the end of the afternoon. What?
They're evil.
They're all evil.
They're all evil.
Me too. But if some people teach the Alexander technique in such a way that people get very conscious about their posture, and my head goes forward and up, and my shoulders are down, and my spine is like this. Well, you don't do posture cortically. And all the things you're thinking about your posture won't mean anything when you slip on a banana peel, because you're going to react from the center reticular formation in your brainstem. All your cortical ideas about staying forward and up are going to go to hell in a handbasket in that moment. And I was very much involved in this when I first did classes with Ida Rolf. We all got ourselves straight, and our pelvis is tucked under, and our waistline back, and the top of our head up. And it's a useful exercise to try, but if you keep it up for too long, you just look like a twit. And it doesn't feel, it's not natural. How do you expose the natural posture within the individual, which is a very individual thing, as opposed to imposing good posture from the outside? And so your question about consciousness is a really kind of back and forth one. Sometimes I want people to be conscious of something because they really could correct a habit that would be very helpful, but mostly I want it to enter the brainstem so that it's totally unconscious, because that's where you do posture, is way down deep in the nervous system. Great question, thanks. So, we're up here now with Karen for our second model. And the same procedure, we'll just do it a little more quickly, is going to pertain. What's your first impression? Look at Karen, look away. Or look at Karen, close your eyes. You guys do that at home too. Just take in who she is. You can look again if you want to. But your first impression is often in your mind's eye image. So it's a good way to do it. If you keep staring at the person themselves, sometimes it's hard to see what you're seeing, or to see your reaction to what you're seeing, which is what you're doing. Your whole body is an antenna, your eyes, your ears, your skin, and you're taking in who Karen is. There's a lot of information there. Okay, so keep that to yourself. It's just something to file away. Even writing it down is a hard thing because it's not exactly a verbal impression. It's a gestalt that happens from her to you. However, you will need to speak 3 good things. What are the positive advantages, accomplishments, feelings, attributes that Karen brings to whatever work we might do together?
So Karen has a very solid stance and very grounded, and I also think that you have very good balance from right to left. You're very well balanced and very well centered over your line, your center line.
Okay, so she's balanced left to right, and she's well grounded. Would that be planted? What else?
I feel that your spine is very straight. Everything seems to be sort of not held, sort of one on top of the other, kind of almost floaty, like there's not much tension there.
So she floats, just like ivory soap. Okay, great.
She's really maintained her figure. She's extremely trim. She seems to be the perfect weight.
Great. Perfect weight for her body.
I'm glad I came here.
Hey, you're doing all right, kiddo. Okay, so I'm forcing you into the exercise, but I would urge it to you in your practice too. See what's positive. See what the person brings. And that's worth writing down, just noting the good things. And, you know, I would add her ready smile. I've really enjoyed her smile in the couple hours that we've been here, and it speaks to the condition of her heart. Yeah, warm-hearted. That's an advantage that we can help in our work. All right. Now, with that, we can say, as long as we know what the positive things are, we can begin to look at what could we improve or make more balanced, or what would be more functional, even more functional than the functional that she is now. That's presumably why she's subjecting herself to this humiliating exercise of standing up with no protection. I'm not even going to let you to cross your hands the way you were before. You have to stand up in front of people. What's the advantage of it is that we can see what we might be looking at in terms of, and we're just using stance as a metaphor for her movement right now. We're using standing to see what could be happening in her movement. So what do we see in her stance? We've already said that she's fairly balanced left from right, but I'm asking you, the first thing to do is to drop a plumb line through the middle and say, well, what's different on left and right? Are the shoulders the same? The hips the same? The knees the same? The feet the same? They really are, pretty much. This is not big issues for her, left and right, is it? No. How about weightedness? If you put a line right up between her feet, where that tape is on the paper, and you go straight up through her body, is she weighted more on one leg than the other?
Yes.
The right or the left?
I think the right.
Okay, you think the right.
She's wrong. I think the left.
Okay, good. Do you want to fight with swords or pistols?
I use the microphone.
Okay. It looks to me, and I can see better from the back. In fact, why don't you turn around just for a sec. Turn your back to them. It looks to me, if I take a line straight up from between her feet, that her upper body comes over more to the left and that she's weighted more on her left. That's what it looks like to me. We'd really need 2 scales, and to slip 2 scales under the feet, 1 scale under each foot. The 2 scales would total her weight, and we'd see how much weight was on each scale. You'd be surprised that even people who look fairly balanced are not as balanced as they look. And if you look up in here, you can see the rib cage coming over to her left.
It's much more apparent from behind it.
Than it is from in front. Yep, people tend to make themselves look good in front because you see it in the mirror more often. However, didn't she just say that she had a problem in the left hip? So how come she's putting her weight over the left hip? You will find this commonly. It's not always that people take the weight off the bad leg. They will sometimes center the weight over the bad leg because then the weight goes straight down through the bones and it's not straining the muscles in the joints as much. So you'll see a lot of folks who are walking around with a cane where the weight is centered on the bad leg because then they don't have all the strain of what happens to the hip when you move the weight off the bad leg. They'll often be sitting on it. So it's not inconsistent that she has a problem with the left hip and her weight is over to the left. People will do that a lot of times. Okay, so we can't find anything wrong with you right to left. So could you turn sideways and face away from me? How about shifts? We were looking at whether the pelvis is anterior or posterior to the feet. What's the answer to that one?
Slightly anterior.
Slightly anterior. If we dropped a plumb line from her trochanter here, we'd run in front of the ankle. Yeah. Let me show you. If I put my forearms, don't use your hands, because if you use your hands, you could easily push forward or pull back. But if you use your forearms, you're just going to lower the weight of your arms onto her shoulders and add to gravity. Yes? Watch what happens to her hips when I add to gravity. Did you see them go forward? Okay, so her shoulders are behind her hips are in front of her feet, so when I put pressure down, it's going to buckle that way, so to speak. That tells you that the hips are in front of the shoulders and probably in front of the feet. So now let's bring her hips, what's going to feel to her like whoa, 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 like she's dropping backwards. And now I'm going to put my hands on her shoulders. She's much sturdier. She's still a little bit forward. You see? Still going a little bit forward. Come back even a little bit more. Yep. And leave your shoulders right where they are. That's great. Now, by God, you are a strong and sturdy person because her hips are over her feet, so it's traveling down through the bones. She's not having to work with her soft tissues. If she goes back to her old posture and we push, that's pushing against the ligaments of her hip as the hips go forward. Yeah.
Do you generally look at the pelvis as an indicator of the whole locus of balance? You seem to have done that on these 2 examples.
Yeah, well, it's certainly in a human structure, the pelvis is simultaneously the top of walking and the bottom of the spine. So in human structure, the pelvis is kind of the keystone of the structure. So it's on top of the two legs, so any difference in the legs is going to show up in the pelvis, but any difference, any aberration in the pelvis is going to affect the spine. An anterior tilt is going to send the spine forward. Posterior tilt is going to make the lumbars curl. Left tilt, right tilt, it's like a tree growing out of a cliff. It goes out and then turns up. So yeah, we tend to look at the pelvis first. Most of you, when you first start doing this body reading, and so it's not a bad idea to start here, tend to look at the shoulders first. But if the shoulders are so often the result and not the cause. The pelvis, I don't know about cause anyway, in terms of cause and effect, but the pelvis is so central that it's definitely worth looking at. Yep. All right, turn back and face the crowd again if you would. Once again, if we looked at top, bottom, what would we see? Does she look larger in her upper body and smaller in her lower body, or the other way around? No, pretty good proportion in there, yeah? So that's not a big issue.
You know, I can actually see my front rotated this way.
Oh, she wants to know about the
I
rotations
just
now.
happened to notice that.
Yeah, okay. So she's looking down. This is the difficulty of looking straight on, as the camera is doing and as you guys are doing. Looking straight on into the body, it's hard to see the rotations. So later on in the photographic section of this, where you can test yourself, we've taken photographs straight down on the body so that you can see the rotations. And I'll just put that in here to turn sideways so the camera can see this a little bit better. If I want to see the rotations in the body, I don't sit out in front. It's the hardest place to see. What I do is an exercise, or what I teach our students is an exercise we call breathing down their neck. So you come and breathe down their neck. It means you get right up close here. I can see the heels, the pelvis, and the mid-back right here. And when I do that, if I think of a line drawn between the two heels as 0, by the time I get up here, she's turned about 2-3 degrees to her right. And by the time I get to the rib cage, it's even more turned to the right. So what we saw with Penny was the pelvis went one way and the rib cage went the other. What we see with Karen is she has a consistent rotation all the way, I'm just way exaggerating it now, from the heels to the shoulders, and then we know, since her nose is going the same direction as her feet, that she must have a rotation to the right in her neck. It's hard to see the rotations in the neck. There's so many muscles, and it's so, it's not a big territory. It's harder to see those rotations, but it must be. If the rib cage is going that way and the nose is going that way, then the neck must rotate to the right in the middle. Her primary rotation is to the right, and her pelvis to her feet rotation is to the right, but that must mean that she has a cervical rotation to the left. So as we unwind the rotation in the below the neck part of the body, we must also unwind the rotation, the opposite rotation in the neck, if it's going to make sense to her, what we're doing. Turn back and face the folks just one more time. How could you see that rotation without looking down her neck? I want to just have this before we go. Does one shoulder look more forward than the other? Can you see that this shoulder looks a little closer than this one? Yep. And then you go down to the ribs. Are the shoulders following the rib cage? Well, if you check it out, you'll see that this is a little bit more forward. And if we come down here, this is really hard to see, but this is also a little bit forward, but not as forward as the ribs, and the ribs aren't as forward as the shoulders. So it's progressively going like that. So we could go all psychological and say she's protecting her right side, or she's calling in. I don't know. I don't know whether it has a psychological meaning or not. I don't think a lot of these things, some people say that they all have psychological meaning. I would say these things all have a psychological component, but sometimes it's a predominant component, sometimes it's a very recessive
My left
component.
ankle was broken some years ago.
Her left ankle was broken some years ago.
When she's has her back facing us,
Oh, turn
so
your back
if you turn
to...
around
Yep.
to your back, it's more evident. It's as though the left leg is out over. It's like her foot is out laterally from the rest of her leg. So instead of coming straight down,
Okay.
her left foot seems to be.
So how would you say that in the language that we just
In
did?
the language, I would say probably, this is the first thing I noticed, that she has a medial tilt of the foot,
Okay?
of the left foot.
A medial tilt of the left foot. Or, if in fact what you say is true is that the leg comes down to here and the foot is out, that would be a lateral shift of the foot.
Right.
However, the way the joints work, it's really hard to have a lateral shift of the foot, so it's probably a tilt. Although, if you look at this Achilles tendon, it kind of looks medially tilted as well. However, with the information that we have that she had a break in her foot, her attempt to get up and over here, and the fact that it's resulted, I said resulted, I don't know, but it's related to probably this injury in the hip, we're beginning to build a story that would help us. So, getting more sturdiness in this left ankle might allow us to bring this hip back so that we wouldn't have so much strain in the deep lateral rotator, so she wouldn't be hurting in the hip joint itself, and then we could bring this back over, which doesn't seem to be causing her much trouble, but looks funny to us with the left shoulder being so far forward. So that begins to bring us into the soft tissue story that we might be working on to help her undo these patterns. So Karen's asked about whether she has a neutral pelvis, a posterior pelvis, or an anterior pelvis. You could get a goniometer on here and measure degrees and do all that kind of thing, but I want a functional definition of what constitutes a horizontal pelvis. Ida Rolf, Kendall and McCreary say, 16 degrees between the PSIS and ASIS, something like that. Ida Rolf said if the tailbone and the pubic bone are on the same horizontal level, but that's really geometric. That really asks everybody to fit into a box. Here's a way, and she has wonderful hair for this, just put your hand into your client's hair, like really lightly touching the head, a cranial 5-gram touch to the head. And we're going to ask you, Karen, to isolate your pelvis and just go into more of a posterior tilt. She immediately, her head goes away from my hand, so I don't want her to come back to normal now. I don't want her to go any more in, I don't want to set her pelvis any more into posterior tilt because that's going to shorten her spine. My value here is a long spine. Where is the spine the most springy, the most expansive? You already called her floaty. That was one of the positive things that you said. That floatiness is an indication that the pelvis is probably pretty horizontal, but let's check. From your normal, go into an anterior tilt. Well, actually, for a few degrees of that anterior tilt, she grew into my hand, and then she started to shrink away again. So if you came into my practice on the basis of this, I would say you still have a slightly posterior tilt. And you want to come just a few degrees anterior to free your spine up the most. Yeah? Again, face the folks. Karen's bringing so much awareness. Her work is in this realm, so if we get to that consciousness question, her consciousness would probably be advanced enough, and her sense of her body would be able to help us. But she didn't know about this, at least as I understand it.
I've been getting a hint working with the Rolfer.
Uh-huh.
And he was working here, and this was the tightest thing I'd ever felt in the back of my ribs here.
Mm-hmm.
And this is like a rock back here.
Yep.
And the reason I asked the question the last time about the equal and opposite is what I've started to notice is that when I try to stretch this just goes like that.
Mm-hmm.
And so what I've been doing is I'm practicing and learning to release this and not have this fire. And it's like, lo and behold, I can actually stretch. So it feels like a good stretch in my lower back.
So that's the kind of thing where the conscious effort can be really helpful. However, it still has to get to a place where it becomes an unconscious thing not to do this. And if you watch my shirt, I think, when I do this, you'll see it fold up. Mm-hmm. Well, I'll make it do that. But anyway, you can see how the ribs would fold up right in here. And it's been that way long enough that these ribs have tied up so that when she tries to move out of it, it burns, it binds, it does whatever it's going to do. It does various things depending on whether it's held in the deeper tissues or the more superficial tissues. But it's talking to her.
But is it
She's listening.
The posture becomes unconscious, and which is a good thing you're saying, after we've released the patterns through this type of work?
If the postural change becomes unconscious, it has a very good chance of staying. If it's only in the conscious and never makes it to the unconscious, it has a very poor chance of staying.
It becomes unconscious how?
Well, the martial arts folks would tell you that it becomes unconscious by repetition, repetition, repetition. That's the basis of the Alexander technique, the Feldenkrais technique, certain training kinds of techniques. The more you train as doing your conscious katas in your martial arts, when somebody comes at you, you just go automatically in them. So that's one theory about this. I happen to like the particular work that I was taught, of course I would, wouldn't I, which is the connective tissue manipulation a la Ida Rolf, which changes the body while you're on the table out of gravity, and then you stand up and you have to figure out what in hell happened during that session. And that process happens largely unconsciously. People will come back consciously saying, oh, I still feel this pain in my neck, and I've been trying to adjust my neck. Meanwhile, their pelvis has really changed. They haven't even noticed, but it's become part of a new thing for them. And capability, what they notice is that things start to become easier. They're not telling you about this thing, but it just became part of them. Those are the ones that I really like. You meet those people on the street 6 months later and you say, well, how are those headaches going that you came to me for? And they say, what headaches? Because it's just passed away. It's just not in their being anymore. They don't have to do anything to get rid of the headaches. The headaches just disappeared.
But is it so that if you can have that sensation even once, I mean, because of the Rolfing, I believe it allowed me, gave me a, it loosened things up or
That's
got
right.
things in different places, and then I was able to experience. I would think I was waking up in bed, and I just kind of did it and said, wow, that feels good.
Yeah.
So isn't it so that once your body feels that, it's more inclined to gravitate back towards it, even if you're...
That's right, but the essential word in what she said was feels. If I just take the tissue and I do my structural work, and she doesn't feel it, there will be the tendency for the body to reassume the pattern that it had before. Yeah? So it's a really dicey thing, this consciousness thing. You have to feel it and perceive it, but then it has to become part of your underlying movement. You know, the argument against the Rolfing idea is people aren't pieces of clay. You can't just smush them into shape and expect them to stay that way because they're run by a mind. So something has to happen with the mind, but the argument from the other side is people aren't just a mind. They're an embodied mind. And if you don't change the body, it's sometimes hard for the mind to change. Now, our principal thing about changing in the culture in the last 150 years has been psychotherapy and psychoanalysis. And you look at this stuff, if you're just talking about something that has a bodily component, like we're speaking about depression. Depression has a bodily component to it. It's stuck here. So if you go to a talk therapy and you take your Paxil and you try to reason through this thing, but you never go after this bodily component, you generally understand more and more and more about why you can't change. But that's really not what we're trying to do here. We're trying to actually be able to change. And I think the body is just, my whole life is dedicated to the idea that changing those patterns in the body is a really interesting and valuable and underserved part of changing these. Anyway, thanks a lot,
Thank
Jackie.
you. Thank
Take
you
care.
very much.
Bye-bye. With somebody like Penny, you see that even a very balanced body can have things that we can find to look for improvement. The question is not, I mean, both of these people were healthy and probably far healthier than I am. And some people say you can't help anybody unless you're better than they are. You know, you've gone farther than they are, and then you can pull them up. I don't believe that at all. I believe that if either, I'm arrogant enough to believe that if either Karen or Penny came to me, even though my level of athletic prowess is nowhere near their own, that I would be able to help them by doing these kinds of analyses, this kind of seeing. You can reach into the body and improve them in their terms. Not improve them in my terms, but improve themselves in their terms. It's obviously better when you have a highly motivated person. That makes it that much easier. But even with somebody who doesn't really know where it is that they want to go, by use of this seeing, you can see where they need to go and open up the way for them to go there. That's all you can do. You can open the door and they can walk through the door. You can't shove them through the door. But mostly people come to you are highly motivated to do that.